patients. Here you have the effect about the experimental data on the left-hand side here of the slide with the animal models considered, and here the effect on the GFR, and you can see all the effect by having beneficial effect on the renal complications, and as you can see here, in particular on the albuminuria, glomerulosclerosis, and so on. And regarding clinical trial, you can see that all drugs have shown an effect on reducing albuminuria, and then as you see, there are also other drug, and in particular here is interesting the effect of vildagliptin in this large study in patients with diabetes and ulcers, and they show an effect that has been typically identified mainly for vildagliptin compared to the others. But overall, in this nice review that was published 26 years ago by Avogaro, it shows that the DPP4 have an effect in protecting the evolution towards kidney failure. There are a number of well-known trials that have made history, I would say, about the effect of DPP4 on cardiovascular complications in patients with type 2 diabetes. And here you have the major trials that have tested the effects of alogliptin, saxagliptin, sitagliptin, and litagliptin. And these are the targets of the definition target for an effect. And this is the main inclusion criteria on this study. And I'm sure you are aware that regarding the DPP4 and the renal and hepatic insufficiency, some of these drugs can be used under different level of renal function. And overall, these drugs, and in particular vildagliptin, where we're talking about, have an interesting effect where they are recommended or not recommended. And these are part of the different criteria used for using these drugs in patients with kidney failure. And then the major trial looking at the effect of the dose adjustment. And you can see what are the dose adjustment according to the GFR and in the different studies. And therefore, you may see that required number of days for screening and so on. But I'm sure you can look at these trials and make your values based on this very nice review article by Hans Syme published in Diabetes and Vascular Disease Research. As far as the position of the DPP4 in the treatment algorithm, according to the ESD and ADA guidelines, you can see that the metformin is first-line therapy, but then as you can see, where you have different complication, there are different positions, and in particular in patients without cardiovascular or kidney failure, to minimize hypoglycemia, DPP4, a second-line therapy is used alone or in combination with GLP-1 receptor agonist. The combination is not recommended here, but it could be combined with other drugs. If weight loss or minimized weight, DPP4 inhibitor is considered as a third line in combination with SGLT2, and when GLP receptor agonist is not tolerated. So the cost is another important factor to be taken into account, in particular in countries where this is an issue. Now, if we look at the vildagliptin for the management of blood glucose in type 2 diabetes, I'm going to discuss with you the major trial that have focused on vildagliptin and to give you an overview of what has been done so far with this drug. Historically, if you look at when this drug has been tested in this trial first with a 24 weeks trial, that was 13 years ago. And that was clearly showing an effect versus placebo plus metformin, and this was vildagliptin versus metformin plus metformin. You can see a reduction in glycated hemoglobin. This study was really the first study showing a strong effect by a percentage, 1% of glycated hemoglobin reduction within a short period of time, because this is a study of 24 weeks. And the mean change of fasting plasma glucose is also observed here. So the other point that I like to underline is that vildagliptin is very well tolerated, and dose-related decreases in HbA1c and fasting plasma glucose was clearly demonstrated. And of course, this was the beginning on a long trip that is still placing vildagliptin today in a very strong position. Then there were a number of studies, the G4 study that was published in 2019, and this is a study of great interest because it's a real-world study where was a prospective observational open-label multi-center study in a total of 1,230 patients. As you can see, the mean age of this patient was 63, and the HbA1c and fasting plasma glucose were typically within patient not a target, and the BMI, typical BMI of patients with type 2 diabetes. And the mean time of diabetes since diagnosis 6.6, so they were not really very long duration diabetes patient, but typical patient that we encounter in our clinic today after a few years of diabetes, well then not controlled because the glycated hemoglobin was 8.2. Now then you can see the reduction in blood glucose over a period of 6 months and of glycated hemoglobin during the period of follow-up, and the proportion of patients that reach glycated hemoglobin less than 7%. So 1 in 2 patients in visit 3 observed a reduction in glycated hemoglobin, significant reduction, and below 0.7. This is a nice study that Luc Van Gaal did, and was a very significant study because it was done on a large population, as I said, over 1,000 patients in the real world. Then again, the cardiovascular risk factors such as BMI, blood pressure, and serum lipid level, you may see here, or how these factors were reduced over time. And this study was followed by parameters that actually definitely indicate that the reduction in total cholesterol, in LDL, in triglyceride, and the systolic blood pressure that was highly significant in patients treated with vildagliptin, suggesting an indirect and indirect improved cardiometabolic profile. So in addition to the glycemic effect, these parameters on the lipid profile and on BMI and cholesterol indicate the potential role of this DPP4 in controlling the very vascular complication in diabetes. Now, the GARD study looked at the effect and safety add-on on metformin. As you can see here, vildagliptin, proportion of patients achieving HbA1c target less than 7% at week 24. And as you can see, the reduction in real-world setting of vildagliptin with or without metformin, it's well demonstrated, suggesting that the tolerance of vildagliptin is good, and the reduction of patients or reduction of proportion of patients could reach up to 70% patient with a glycated hemoglobin below 7%. Regarding another interesting mechanism of action of vildagliptin is the effect of improved meal-related beta cell function. Now, the meal-related beta cell function is relevant because patients with type 2 diabetes tend to lose beta cell function. And we know that losing beta cell function could be a parameter that can speed up some complication. And this study looked at the evidence that vildagliptin, when added to metformin, improves the beta cell function, the insulin secretion in patients with type 2 diabetes, and then improving also insulin sensitivity. So this was observed in 1 year, and that was immediately seen already after 12 weeks, both for the insulin secretion and insulin sensitivity. So this patient, by increasing insulin secretion and insulin sensitivity, may remain eventually for a longer time free of insulin therapy, so free of injection and well controlled. Another study looked at the long-term efficacy and safety of vildagliptin as add-on on patients treated with insulin. As you can see here, the addition of vildagliptin on patients, these are the different doses, as you can see overall, at 100 milligram and at 50 milligram. the addition of vildagliptin to insulin therapy improved metabolic control within a short period of time. And this is already seen after 3 months of treatment. So again, this is demonstration that the DPP4 added on to insulin may have a beneficial effect in patients with type 2 diabetes. Now, this is another study looking at the chronological changes in dose of insulin injection in patients with vildagliptin and control groups. As you can see, the changes in daily insulin dose. Not only we have an increase in metabolic control, but also you see a reduction in insulin dose. This could be beneficial because it may control the body weight that, as you know, patients with type 2 diabetes tend to have when you add insulin. So this is another parameter that you can keep in mind when patients need insulin, and then having a better metabolic control and also a better control of body weight. Of course, sulfonylurea are still used as a drug for diabetes, in particular for the lower cost. This is a post-hoc analysis, the EDGE study, where the effectiveness, safety of vildagliptin versus other oral anti-diabetes drug as add-on to first-line sulfonylurea in patients who did not receive metformin in a real-life setting. And as you can see, as it added to monotherapy with sulfonylurea, the vildagliptin show a better metabolic control as a reduction in glycated hemoglobin of 1.36 and highly significant. And also the mean changes in body weight. As you expected, you have a reduction in body weight by combination with, in the EDGE study, by combination with vildagliptin. Other studies that show an effect of vildagliptin is the comparison between vildagliptin as an add-on therapy and sulfonylurea dose increase therapy in patients that were not controlled with diabetes using metformin and sulfonylurea. So again, here you see at 12 weeks, the effect by the adding vildagliptin, you have the reduction in plasma, in fasting plasma glucose, and this is the mean reduction of 2 hours plasma glucose by adding vildagliptin. And on the right-hand side, you have the reduction of 1.20% roughly of vildagliptin when you add to metformin plus sulfonylurea. So even in patients with double treatment, sulfonylurea plus metformin, the addition of vildagliptin was able to reduce significantly glycated hemoglobin and improve metabolic control. Then in the visual study, again, we have the hypoglycemic events. We know that the use of sulfonylurea for hypoglycemic induction is a well-known finding now. And as you can see here, the hypoglycemia events and the patient achieve HbA1c of 40%. And you can see the reduction of the hypoglycemic events in these patients. So not only improving on metabolic control, as shown here by the reduction in glycated hemoglobin, but also a reduction in the hypoglycemic events. A comparison with glimepiride. So this is vildagliptin with glimepiride as an add-on to metformin. And so vildagliptin was added, and you can see that is as effective as glimepiride over a period of 2 years with low incidence of hypoglycemia and no weight gain. So this is a study that was published 10 years ago, but was interesting because it can control the body weight. It was done in 3,118 patients. These are, as an add-on therapy, you can see tremendous reduction of hypoglycemia by adding vildagliptin to glimepiride. And as you're shown here, the number of hypoglycemic events, the number of patients with hypoglycemic events, and the number of severe hypoglycemic events that was maintained in these patients over 16 years of age. So again, the hypoglycemia in patients that are elderly is an important target of our therapy. Remember that one of the major problems for patients with long-standing diabetes is hypoglycemia. So we need to control hypoglycemia, and the addition of vildagliptin has been effective in this respect. Now, body weight. This is always compared to glimepiride, and you can see the change on body weight. And this is a study that was initially published when the first studies were carried out, and you can see that reduction and compared to glimepiride, and also between treatment difference, the reduction was highly significant. And finally, an effect on pioglitazone. Also, a study on versus pioglitazone was done. And look here, the glycated hemoglobin, and then you can say very similar. Look at the body weight. The body weight was a highly significant increase of body weight in patients with pioglitazone compared to vildagliptin, where this was not observed. So this work of Jerry Bowley will also clearly indicate the effect of vildagliptin in controlled body weight compared to a drug that we know changed body weight significantly. And then the title of these slides, in particular in patients greater than 35 BMI, so patients with very high, very high body weight, are obese or second stage obesity, and then pioglitazone added great body weight burden to this patient, and you can see the effect in reduction body weight in patients treated with vildagliptin versus PIO. And as you can see here, the number of patients showing this effect. So again, also on body weight, the effect is significant. And finally, on vildagliptin, a study on diabetes, I'd like to show the VERIFY study, because this VERIFY study is the latest of the many, many trials. And by reviewing the topic, I'm sure you appreciate how many trials have been done over the past 13 years with vildagliptin in patients with type 2 diabetes. And what is about the VERIFY trial in the context of other trials that have been carried out so far? As you can see, as you can see here, these are the main HbA1c at baseline of the different studies. This is the VADT, the leader, the DECLARE. I'm sure you are very familiar with this study, looking at linagliptin, at SGLT2, and then the ADOPT study, the UKPDS. And look where stands the VERIFY. All these studies look into patients with long duration of diabetes. Whereas VERIFY was the first study really looking at the starting the use of vildagliptin in patients newly diagnosed. I like to focus my attention to patients with newly diagnosed type 1 diabetes, because really we do not pay enough attention to patients with newly diagnosed type 1 diabetes. I really dedicate most of my time with patients with type 2 diabetes in my clinic when patients are recent onset, because you need really to educate the patient and try to intervene, not only to control metabolic control and obtain a good low glycated hemoglobin, but you need really to change the natural history of type 2 diabetes, because you need to try to block the evolution versus complication, and you need to intervene to control diabetes very well in the first years. And the patient should be aware how important it is to avoid that the disease is poorly controlled in the first year, and to start having additional drugs and having complications. So the VERIFY study, it's a study of great interest because it tried to change the natural history of type 2 diabetes in addition to control blood glucose level. Now, what about this VERIFY trial? This is a multinational, multi-ethnic study. As you can see, there were 2,000 patients, 250 centers in 34 countries. So it was a study run around the world. And what about the treatment? The treatment was what you expect to give to a patient with type 2 diabetes at diagnosis: metformin. So the study was, what about giving patients with the newly diagnosed disease metformin plus vildagliptin versus metformin and placebo? Time to failure, control, metabolic control, and so on. So this is how the metformin was titrated, obviously, because we know about titration of metformin is interesting. And this is a study, as I said, that was designed to see what the outcome could have been by adding vildagliptin at diagnosis of type 2 diabetes. These are the results. The study were published in The Lancet by David Matthews et al. And this is the time to treatment failure. And as you can see here, the early combination treatment strategy, with the one that we take into consideration, reduce the relative risk of time to initial failure by 50% versus initial monotherapy strategy. And this is really an important factor. And as you can see how that happens straight away. And this is why I concentrate my attention that were really newly diagnosed within very few months from the beginning of the disease. And this is the success rate between treatment. In blue is the early combination, and then is the initial monotherapy. And as you can see, what the difference in HbA1c. And then you have an immediate results, as you can see here, in the early combination and initial monotherapy. And when you go into the change in body weight, as you see here, the body weight patients with the early monotherapy and the patient with early combination have no significant difference. And when you look into the initial monotherapy versus the combination, early combination and the macrovascular event, and when I said changing the natural history, that means reducing the cardiovascular complication that is the major killer in patients with type 2 diabetes. It's just not simply blood glucose. It's here. This is, although more indicative studies, more indicative, this is an indicative signal. Of course, the hazard ratio is that, but it's not significant. But then definitely this indicates that there is a signal that the early combination can reduce the time towards the first vascular event in patients with type 2 diabetes early diagnosed. So the key finding of the study that the early combination treatment halves the risk of time to initial treatment failure versus monotherapy strategy. The median time to failure was 3 years in the initial monotherapy strategy compared to 5 years in the early combination strategy. And then when all patients receive combination strategy, the risk for time to second treatment failure was reduced by 26%. And both approaches were safe and well tolerated. The strategy of early combination treatment approach, including metformin with vildagliptin in patients with newly diagnosed type 2 diabetes, significantly consistently improved long-term glycemic durability compared to metformin therapy alone. Now, what about vildagliptin and cardiovascular complication in patients with type 2 diabetes, based on what we heard? Now, as I said, cardiovascular and renal complications are the main cause of death in people with diabetes around the world, and this can be avoided by appropriate treatment. We now have a new opportunity by thinking that we have to intervene very early in the natural history of complication in patients with type 2 diabetes. And that's what we said with the VERIFY study is a good indication how important it is to intervene early. So cardiovascular disease in type 2 diabetes, what we can say that is the leading cause of disability and death in patients with diabetes. Patients with type 2 are 2 to 6 times more likely to attack or stroke compared to patients without type 2. And people with diabetes are 2 to 3 times more likely to have cardiovascular disease than those without diabetes. And 1 out of 4 patients in patient costs are consequence of cardiovascular complication. Now, this slide is crucial to say that we need to intervene to avoid patients developing more and more complications. What about number? Here, this is the prevalence in number, up to 41% of the history of cardiovascular complication, including stroke, coronary artery disease, and peripheral artery disease, up to 14% of the history of heart attack, up to 10% of history of stroke. These are data from the IDF, and these are patients with a population of 50 to 69. Remember that the VERIFY, when you start early, better is the effect. Now, this is how many people die, and the up to 27 patients out of 1,000 died for cardiovascular disease each year. And mean age of this population was 40 to 69 years, and up to 7 per 1,000 died for coronary disease each year. And these are the studies. Look at the cardiovascular event and mortality rate with DPP4. Now, this is ALO, SAXA, CETA, LINA, and VILDA. And these you have the effects in those trials. It is remarkable the number of patients that have been tested. Look, 29,000, 41,000 is really, really a large studies. And the primary composite cardiovascular point was looking at the effects altogether. And as you can see, the results shown here in some of the slides. And then you can see that the vildagliptin here has a very significant effect in doing this versus the primary composite cardiovascular endpoint. And when you look at the cardiovascular and heart failure, as you know, the DPP4, some of these DPP4 have a potential increase of heart failure. As you can see that vildagliptin show no effect in terms of heart failure. So suggesting that is safe in that respect and compared to comparators. This is vildagliptin safety in type 2 diabetes by looking at a number of other factors, and this is a European non-interventional post-authorization study that was published 3 years ago. And as you can see here, with a high confidence interval, these are the effect of myocardial infarction, acute coronary syndrome, stroke, cardiac failure, the composite cardiovascular event. You can see where it stands, and so compared to the other, you see the effect of vildagliptin regarding safety in patients with type 2 diabetes on cardiovascular complication. And then here again, you look at the risk ratio for adjudicated composite endpoints and its individual effects with vildagliptin versus comparators. And you see here that there is no issue regarding cardiovascular safety in patients with treated with vildagliptin. And finally, what about vildagliptin and ventricular function in patients treated? You see on the heart failure, and then the left ventricular function compared to placebo, you see there is no signal of an increased effect. So we can definitely say that in this respect, vildagliptin is very safe. And then what was really final answer about the potential association of DPP4 versus, and in particular vildagliptin versus other complication, and in particular all these complications associated, including liver disease and previous coronary condition, there is clearly no effect, and this drug is safe in the affected singular factors associated with general outcome in patients with type 2 diabetes. I'm going now to show a few slides about vildagliptin and management of renal impairment in type 2 diabetes. And what can we say? That 1/5 of people with diabetes have really the problem of developing chronic disease. 19% show signs of stage 3 or higher, and the data from 54 countries show that 80% of end-stage renal disease cases are caused by diabetes, hypertension, or a combination. So this is 80%. So it's a huge number of patients that get into kidney failure with diabetes. And so the prevalence is also 10 times higher in people with diabetes compared to those without and hypertension. And people with diabetes and clinical nephropathy experience 50% higher health expenditure compared to those without nephropathy. So it is really a condition that we need to target. And as we know, clearly the effect of the best way of treating patients that are progressing towards severe renal failure is insulin. But look at what happened when you do vildagliptin and placebo on the HbA1c in patients already treated with insulin. A very significant reduction of glycated hemoglobin from about roughly 0.9% compared to insulin and placebo. And this is insulin and vildagliptin, with reducing also without increasing the number of hypoglycemic effect and severity of hypoglycemic effect and weight gain that we expect with the reduction in HbA1c. And then in patients with hemodialysis, where this was given, and as you can see the results showing that in patients with end-stage renal failure, patients treated with vildagliptin could be getting a promising effect for not only for metabolic control, but also for safety. And this is finally a comparison of vildagliptin and sitagliptin. Sitagliptin is another well-known DPP4. And then you can see the reduction in HbA1c, and the reduction in black is vildagliptin versus sitagliptin in patients with severe renal impairment, and as you can see also on glycated hemoglobin. So all these three parameters, in particular, these two parameters, the fasting plasma glucose and the glycated hemoglobin at less than 6.5% show a better effect of vilta versus sita. Finally, the vildagliptin for the elderly. What about vildagliptin in the elderly? As I mentioned before, one critical factor is represented by hypoglycemia, and you can see here the effect of hypoglycemia in patients treated with vildagliptin, definitely reduction in hypoglycemia, and as you can see, the reduction also in HbA1c as we expect. And also here, try to look at the feasibility of using the individualized HbA1c targets in patients with elderly patients with type 2 diabetes treated with vildagliptin. And this is the interval studies, a 24 weeks randomized double-blind placebo control. And you can see here the effect in favor of vildagliptin versus placebo in reaching changing of glycated hemoglobin that was highly significant compared to baseline versus patients treated with placebo. And I'm going to conclude my presentation by talking about diabetes and COVID infection. This is something new, and I will, and I'm asking you to pay particular attention on some of these slides, because these are the first time that these slides are presented. Something has been published, is available on the PubMed yesterday and today. And so we can go through that, and maybe these slides can be helpful for some of you that are already dealing with patients with COVID-19 infection. Now, as you know, Italy is the country with the largest, at the moment, number of patients that have with one recently, about yesterday, these are data about 17 on March, but yesterday, the number of people that died in Italy reached 13,000. So if you look at this data on the 17th of March, the median age of 2003 Italian patients that died while being infected was 80. And so this is why you can get Italy, don't forget Italy is a country with the largest population in Europe, together with Spain. This is why Italy and Spain have got so many people that died, because population is old population. And if you look at these 2,000 patients that died, the mean age was 80, and 70% were men. And among these 355 disease patients with available information on comorbidities were diabetic. So we have 35.5% among this population with diabetes. And in 2018, the prevalence among Italian citizens with the same age range and sex distribution was 20%. That means that the ratio of diabetes among patients who died with SARS-CoV-2 infection compared to the general population was 1.75. So definitely we can conclude that diabetes may not increase the risk, but can worsen the outcome of this new coronavirus disease, with 35% of patients among this population that died. Now, if you look at what has been published yesterday by Gu et al., that is the Gu et al. And also other people, other studies in China, looking at the prevalence among SARS-infected patients of diabetes, you can see that you have an increased prevalence of patients with diabetes. But this is China, and China patients with diabetes are younger than patients with diabetes among Caucasian, and in particular among Italian patients and Spanish patients. So clearly, with the age, you have an increased number of patients with diabetes. And this is the forest plot of diabetes ratio among patients with more severe versus those with less severe form of diabetes. In other words, those that have admission into intensive care, and this you can see the relative risk in patients that have diabetes. So the paper that was published in Diabetes Metabolic Research Reviews yesterday, and just to remind you that I'm editor-in-chief of Diabetes Metabolic Research and Reviews, is regarding the diabetes as a risk factor for the progression and prognosis of COVID-19. And this is the first study that look at medical history, symptom and sign, laboratory findings, chest tomography, and other information about these patients that were admitted in China with coronavirus infection. This is what about the CT scan and score. As you can see, these are the COVID plus non-diabetes patient. This is the diabetes patient. And as you can see the pictures, clearly there is a different picture between patients with or without diabetes. So that's why patients with diabetes tend to have more severe pneumonia and tend to die more frequently than patients without diabetes. And this is really remarkable, and I'd like to pay attention here. Look at some standard blood tests. Look at the lymphocytopenia in the diabetic patients. Look at the increased neutrophils. So this is an abnormal feature of patients with type 2 diabetes, more neutrophil and less lymphocytes. Look at the C-reactive protein, an increase in C-reactive protein, an increase in ferritin, an increase in the erythrosedimentation rate, and the D-dimers and the interleukin-6 that represent the most important parameters of the cytokine storm. As you said before, how important is the cytokine storm to explain the evolution and the admission to intensive care unit of patients with diabetes. So they have a cytokine storm compared to patients without diabetes. So the results show that excessive uncontrolled inflammation and hypercoagulable state associated with dysregulation of glucose metabolism occur in patients with COVID-19 and diabetes. And in related biomarkers to inflammation, such as IL-6, C-reactive protein, coagulation index, D-dimer were higher in diabetic patients compared to those without, suggesting that patients with diabetes are more susceptible to an inflammatory storm, eventually leading to rapid deterioration. So this paper concludes by saying diabetes should be considered as a risk factor for a rapid progression and bad prognosis of COVID-19. So if you think for a moment, and you have a patient with diabetes, in addition to control metabolic control, and as you know, all patients are treated with insulin when they are getting to sub-intensive care, but these patients need to be controlled also for the inflammatory status. The inflammatory status is something new that we were not aware of during the COVID infection. And this is why I think that in the editorial that was published, and you find that on PubMed as well, published yesterday, they conclude in this editorial, unveiling the interaction of two pandemics that among different cytokines found significantly higher in patients with diabetes compared to those without. Interleukin-6, which is already increasing condition of chronic inflammation, including type 2 diabetes, may play a more deleterious COVID infection. Targeting the overexpression of IL-6 with a monoclonal antibody against IL-6 receptor. I'm sure you're aware that it's been discussed about the use of monoclonal antibody tocilizumab. This is used in rheumatoid arthritis, or considering other molecule uses still in rheumatoid arthritis, including the Janus kinase inhibitors, may be of particular interest for treatment of COVID, pneumonia, and diabetes because of the reduction of the effect of these inflammatory cytokines. But an idea that can emerge, and it has been already presented in an editorial published yesterday by Jacobellis online, and you may find online, is the role of the DPP4 inhibitors in the COVID infection. And I put a question mark there. You remember the first slide I showed you about the effect of the DPP4 as an anti-inflammatory drug? DPP4 was discovered as a receptor for Middle East respiratory syndrome. Indeed, the infection is coming through the CD26, that is the DPP4. The DPP4 is located around the body, so we may think that if the target of the COVID-19 is the DPP4, and that you use the DPP4 by infecting the cells, by inhibiting the DPP4, you may re-inhibit the progression of the disease, and the fact that this treatment that of course, as we know, is used for lowering medication worldwide, means the DPP4, could be of interest to find out whether they might protect against coronavirus infection and prevent deterioration of COVID-19. Have a look at these two papers that have been published and the commentaries, because it opened a new area of interest. And of course, this is just a proposal. At this time, we have to consider that the DPP4 in the COVID-19 infection may have a role. Who knows? We have to look to all data that are available. Now, you can imagine how many patients are admitted with diabetes around the world, how many patients are treated with DPP4 or not treated, so we can give an answer by looking at the notes of these patients. And I think this is a very interesting opportunity by considering DPP4 may be a drug to consider among the others in intervening to control the spreading of the COVID-19 in diabetes. So I'm going to conclude by saying that DPP4 is a category of agents that, in addition to improve metabolic control, may have an effect on not only here, but also without causing hypoglycemia. A result or outcome, I provided reassurance regarding the cardiovascular disease, and you are very familiar with that, and appear to be safe, and vildagliptin is more effective in decreasing insulin requirement and achieving glycemic control when compared to the other two. And regarding the effect of vildagliptin compared to acute glucose fluctuation, there is an effect, also an effect compared to sitagliptin, looking at the hypoglycemic effect and the local effect, and also comparing to the effect of vildagliptin regarding body weight and safety of cardiovascular complication and moderate or severe renal function. I think that this drug may have, in addition to the antihypoglycemic efficacy, an effect very interesting in patients with normal renal function that tend to have a slight moving towards renal failure, in particular with insulin. And also it's been shown efficacy is safe and well tolerated. And I conclude that if you look at the literature, and some of you may be interested and look at the effect of vildagliptin as immunomodulator, you will find that vildagliptin, among the different DPP4 available, is the one that has been shown very many years ago, in the 2009, 2010, was used as an immunomodulator, as a drug that could actually modulate the CD26, that is the DPP4 on T cells, and be used as an immunomodulator, and potentially been considered also in patients with type 1 diabetes to reduce the inflammation within the islet cells. So now we may see a new area of interest that this drug may have for the interference with the process that may lead to a deterioration of the COVID infection. And who knows, and the time will tell us whether it may be of interest to find whether this could be effective also in protecting from the coronavirus infection. Of course, this is the beginning of an interesting time, and we have the opportunity to look into that for future studies. Thank you very much indeed for your help.
Thank you very much, Professor Pozzilli, for this very elegant presentation and the valuable information about COVID-19 and in diabetic patients. Would you allow me just a few minutes to wrap up this excellent presentation? Professor Pozzilli started his lecture by giving the mechanism of action of DPP4 inhibitors as a group and its beneficial effect on cardiovascular and renal complications, especially albuminuria. Also, he specifically spoke about vildagliptin and its use in hepatic and renal insufficiency and the importance of dosage adjustment. Major trials were also presented on the group, and particular on vildagliptin and its effects on other parameters like lipid profiles and BMI, etc. Also, he mentioned the effect of meal-related beta cell function and the value of addition of vildagliptin to metformin, to insulin, and to sulfonylurea with the synergistic action of both of these drugs. And also the use of vildagliptin in elderly patients, to avoid the hypoglycemia, and in the newly diagnosed patients, especially in early years, for the importance of the legacy effect or glycemic memory. In full details, Professor Pozzilli represented the verified trials and in full details, and he concluded his lecture by a series of slides on diabetes and COVID-19 infection, where diabetes is a risk factor in prognosis and progression of the disease, and he mentioned the mechanisms of this progression and its dangerous effect on diabetics. So I would like to ask all our diabetic patients to stay at home and to be examined for the virus. At last, we have very few questions. I would like to ask Professor Pozzilli. The first question is about the role of DPP4 inhibitors in NASH and fatty liver.
Now, I did not cover that. There was only one slide covering the effects in patients with cirrhosis. The NASH is at the moment a very hot topic. It's really an area where there are a lot of studies. So I think that there was only one study looking at the vildagliptin showing that was safe in patients with progression towards cirrhosis. So I'm not aware of recent studies, but definitely is something that we'll see more and more studies ongoing with this drug.
Okay, I think also that in the pipeline, there are many drugs now tried to attack the NASH and fatty liver. Now, another question about the effect of vildagliptin on cardiovascular system is it due to glycemic control or it is a molecular effect of the drug?
Well, I think that even for the cardiovascular effect, probably the best way to consider the effect is an anti-inflammatory, because we know that the inflammation plays a major role. So I will really reconsider all the effect, the so-called extra-glycemic effect of vildagliptin, looking at the anti-inflammatory property of this compound. So it works pretty well conceptually for the complication at cardiovascular level.
Another question, Dr. Pozzilli, can vildagliptin be used in pre-diabetics?
Now, vildagliptin in pre-diabetics, you know, I think that we need to modify the natural history of the disease. So in pre-diabetes, of course, we know that intervening very early during the phase of the pre-diabetes stage, we can, if the patient is compliant, prevent the disease developing. And by looking at the mechanism of action of the DPP4, clearly inhibitors, and in particular also vildagliptin, it could be an interesting study to perform. If we do a study of this kind, we will have an answer. Conceptually, it's a study that can be done.
Right. Another question, can we combine DPP4 inhibitors, metformin, and SGL2 inhibitors?
Well, now the combination of SGLT2 inhibitors and DPP4 depends where you are. There are countries where this is reimbursed, and some other countries where it's off-label. So in terms of say yes or no at the combination, it depends where you are, and then also depends on what is the evidence of studies showing that there is such an effect. Conceptually, the DPP4 and the SGLT2 could be combined.
All right. I think last question to save time is about safety of safety in pregnancy.
Safety in pregnancy. I think that usually that we have no data about it.
Oh yes, yes. Okay. I have to thank you very much and thank the audience and thank Eva Farm. And I think that Dr. Nihal will speak a few minutes now.
Okay. Thank you very much. I'm listening to Dr. Nihal. He's going to speak in English or in Arabic.
No, I think it's yes.
I will start by English and I will finish by Arabic.
Okay, so start in English and then Arabic.
I would like to thank you first. I would like to thank you first, Professor Paulo, for this elegant presentation, and especially the slides of COVID-19 slides with vildagliptin, or the updates that you mentioned that were published yesterday and today. Really very precious slides, all of them specifically the COVID-19 slides. So thank you so much for this eminent and elegant presentation. And thank you so much, Professor Fahmy, for the moderation of this session and your attendance as well. I would like also to thank all the attended doctors from Egypt and from other countries, especially from Yemen, Libya, Sudan, and south of Sudan, and Iraq as well. Specifically, I would like to thank also doctors from Libya, because there are large numbers of doctors that attended this meeting. So a specific thank for them and for all the attendees. فحابة أشكر حضراتكم كلكم وكل البلاد من مصر ومن ليبيا ومن العراق والسودان وجنوب السودان والإمارات كمان. حابة بس أشير مع حضراتكم نقطة مهمة جدا. حابه تشير مع حضراتكم الافيلابيلتي بتاعه الجليبتس. الجليبتس حابه اشير مع حضراتكم ان هو افيلبل في كل الكونسنتريشنز بتاعته طول الفتره اللي جايه، سواء جليبتس بلين او جليبتس بلس. الجليبتس بلين هو 3 شرايط ب 95 جنيه وربع، والجليبتس بلس ب 134 شريط. حابه اكد ان هو افيلبل، متواجد، هيفضل كمان متواجد، لانه اي ثينك دي نقطه مهمه جدا بالنسبه لحضراتكم، ان انتوا تعملوا بريسكريبشن لبرودكت اوريدي موجود في الماركت وهيكمل موجود في الماركت، اند وي انشور انه موجود في كل الصيدليات على مستوى الجمهوريه وفي كل الموزعين. فاعتقد دي حاجه تفرق لينا كلنا، ان احنا فعلا نوفر الدواء لكل المرضى اللي محتاجين دواء زي جليبتس، لان هو كرونيك تريتمنت. فدي مسؤوليه علينا، واحنا وي ار كوميتد بيها، ويشرفنا ان احنا نكون دايما بنخدم المريض المصري. الحاجه الثانيه اللي انا عايزه تشير مع حضراتكم، طبعا كل سنه وحضرتك طيبين، رمضان خلاص يعني على الابواب، قرب جدا يكون موجود. فحابه اكد على حضراتكم بس انه it's time to add Gliptus or Gliptus Plus لكل البيشنتس، او طبعا مش لكلهم، اكيد في individualization، بس للبيشنتس هو الفاست رمضان، لانه بينشور السيفتي والافيكاسي at the same time. بضمن كمان البيشنت انه ما يكسرش صيامه، لان اكيد دي حاجه تفرق جدا للبيشنت ولحضراتكم كمان. فالفيلداجليبتين جليبتس او جليبتس بلس بيساعد على النقطه دي، ان البيشنت يقدر يعدي فتره رمضان بسيفتي وافيكاسي من غير كمان ما يكسر الصيام بتاعه. فحابه اشكر حضراتكم كلكم من كل البلاد على تواجدكم والانتراكشن بتاعكم معانا. شكرا. دكتور فهمي، في اي كومنت لحضرتك؟ بروفيسور فهمي. Okay. Finally, I would thank you all for your valuable presence. إن شاء الله نشوفكم على خير في ويبينارز قادمة إن شاء الله، وحاجة تكون مشرفة زي كده. Thank you, Professor Paulo. Thank you so much. Thank you, Professor Fahmy.
Okay, thank you. Bye-bye.